Thank you, everyone. We're glad that you could join us. I'm going to get started. First, I would ask that everyone please mute your phones and be mindful if your cell phone is near your landline or your computer. Welcome to the Learning Curve, a Geriatrics Professional Development Series. My name is Lauren Jones, and I am the Program Manager of the Geriatric Scholars Program at the Greater Los Angeles GRECC. We are pleased to welcome you to the third year of this webinar series. This is the second webinar in a two-part series this year. The topic today is improving clinical care through quality improvement, and our speakers will be Dr. Carol Callaway-Lane and Dr. Judy Howe. If you cannot access the live meeting, please go to the following link: slideshare.net/C as in cat, A-double-L-A-W, C as in cat, L. I repeat, slideshare, that's S-L-I-D as in dog, E-S-H-A-R-E.net/C as in cat, A-double-L-A-W-C-L. At this site, you can also access the slides. This series is sponsored by the Employee Education System, EES, in collaboration with the Consortium of New York Geriatric Education Centers, the Arkansas Geriatric Education Center, and the Geriatric Scholars Program. The presentation will last approximately 45 minutes with a question and answer session of approximately 15 minutes. Please type in your questions under the Q&A tab on Live Meeting, and the presenter will verbally answer your questions in the order in which they were received at the end of the session. If necessary, you can raise your hand by using the Q&A tab. The hand icon is located on the far right-hand side. Again, please mute your phone, as we have on average 70 callers on the webinars. This session will end promptly at 4 p.m. Eastern. If you have any further questions for the speakers, please send them to me at lauren.jones@va.gov, and I will forward your questions to them. To complete your registration and receive CME, CEU certificates, VA employees must log into TMS using the registration link on the webinar flyer. If you need more information about registration, please contact me at lauren.jones@va.gov. Now, I would like to introduce our speakers for today. Dr. Carol Callaway-Lane is the co-director and education director of the Geriatric Scholars Program Quality Improvement course at the Tennessee Valley GRECC. She is a pulmonary nurse practitioner at the VA Tennessee Valley HealthCare System. As well, she is assistant professor in the Vanderbilt University School of Nursing in Nashville, Tennessee. Dr. Judith Howe is the Associate Director, Education and Evaluation at the Bronx GRECC and the Director of the New York Consortium of Geriatric Education Centers. As well, she is Professor in the Brookdale Department of Geriatrics and Palliative Medicine and Professor in the Department of Preventative Medicine at Mount Sinai School of Medicine in New York, New York. With that said, it is my pleasure to welcome Dr. Callaway-Lane and Howe. Dr. Callaway-Lane?
Thank you, Lauren, and thank you, everyone, for being here. I may take just a moment, and now that Lauren has provided an introduction, I am going to manually mute everyone except for myself, just to have the sound quality be as pristine and clear as it can be. So please utilize your raising your hand if you do have a question.
What I really would like to talk about today is focusing on methods of measurement for quality improvement. And the objectives, as you see here, are to identify some of the strategies that can be routinely included into systems improvement into your own clinical practice. And by ways of doing that, I'd like to focus on the creation of a tally sheet and a Pareto chart to identify specific areas of focus for improvement within clinical practice, and then use the information gathered from a tally sheet in a Pareto chart to create some well-defined process measures to collect baseline data and then to monitor improvement as you make change. And then finally, I want to discuss utilizing these methods of measurement in order to determine the impact of steps of change. And then to the next slide. So improvement in clinical practice. What do we really want to do here? You know, we're all, I presume, everyone on the call is a clinical provider at one degree or another, and we are potentially caring for the veteran population who deserve the best care possible. They've served our country, so it's now our turn to serve them. And we probably can all say that, you know, we do our best. We certainly don't come to work in the morning and say, you know, I'm only going to give 50% of my effort. And we probably come to work really wanting to make a difference. But if we come to work in inefficient systems, that doesn't equal great care. So no matter how good and how hard we can work, if we are working in inefficient systems, then we can certainly find room for improvement. And then finally, we need great support systems behind us so we can provide that good care. So how are we going to do this? And what I have here is the model for improvement, and this is the improvement methodology that's been adopted by the Institute for Healthcare Improvement. And it's really a simple model that can be applied to complicated processes within our healthcare system to sort of tackle the issues that are of burning concern for us. And if you start here at the top, and if you are on the live meeting, you can see here with my little dot, you start by focusing on what you want to change. What are we really trying to accomplish here? And then once you define what you want to accomplish, then you have to go through a few steps of deciding what measures, what are we going to change, and how will we know that those changes are actually an improvement, and then go through the process analysis of making those changes to see what results we have in an improvement. And in doing that process analysis, you'll go through multiple steps of what we consider the PDSA or PDSA cycle, which is plan for improvement. You do the improvement, then you study the results, and then you ask yourself, was this an improvement? Should I continue this? Did it not work? Should I regroup and look at other options? So what this model really does for us, it guides us to think early about defining success, defining what we really want to accomplish. And then it also helps us to create concrete forms of measurement, things that we truly can measure very simply and easily, and then how to use these measurements to evaluate for an improvement. And then the next slide. What I'm going to focus the remainder of the talk is to really focus in on these measurements and how will we know that if a change is an improvement, and help us to identify the best way to go about this measurement. And then to the next slide. So conceptually, I want to offer two different types of measurement. There's a measurement for discovery, and then there's a measurement for actual change. And if we think about measurement for discovery, that's an opportunity to say, you know what, this is really a problem, I think, in my clinic, but how do I know that this really is what I'm worried about, if this truly is what's going on? And it's an opportunity to sort of brainstorm with the thoughts that you're having, and then to identify some common and potentially some uncommon causes. When you go through the process of measuring for discovery, you want to include not only your perspective of the problem, but reach out to all of the providers or all of the other employees that may be impacted by the issue that you have of concern and get their perspective. And that's where you may come up with some of the more uncommon causes that maybe aren't within your line of view that you wouldn't consider but have a major impact. And then measurement for actual change. This is a way to say, okay, if this is what we want to change, where are we starting from? How bad is the problem? We consider that our baseline measurement. And then once you have a baseline, then you consider an opportunity for rapid cycles of improvement. So wouldn't it be great if we could all have Curious George's view here that's seen on this next slide, a view from the catwalk of this wonderful candy factory, and just to be able to remove ourselves from the situation that we find ourselves in that we really think needs to be improved, and to step back and to look at the entire process from an objective point of view so you can see all of the nuances that take place within that system. That's sort of what we want to talk about, how we can subjectively step back and have that view from the catwalk. So let's think of a case study, and this is a case study that I will carry through the rest of the talk. Let's have the scenario that a clinical provider is experiencing frequent occurrences of their patients being placed in the exam room well after the appointment time, which is causing long delays. The provider's waiting for the patient to come in, so therefore the next patient's waiting, so the wait times are getting longer and longer, and patients are getting a little frustrated having to wait too long. So the question is, well, why is this happening? And the first reaction was, well, they must be getting delayed at the clerks, at the check-in, so there's a delay in that process. Well, do we really know that that's what's causing it? So measurement for discovery is a way to identify the potential areas for measurement, to actually question really what is going on in the process. And it's very important to assemble a team, because from that one perspective, it may seem like the delays are all happening at the clerk's desk, but if you gather more people, include a clerk in your process of discovery, maybe include the check-in nurses that do the vital signs, maybe the pharmacist if you have a pharmacist in your clinic, and then look at the entire process to understand what's going on. You may find other issues that have come up. So when this group got together, this hypothetical team that we've put together, they sat down and they did some brainstorming, and they came up with a few ideas that they seem to notice more often than not. That the patients are arriving late, that there maybe are a few delays at the desk, that sometimes the rooms are just not available, so the nurses do their vital signs but then have no place to place the patient into an exam room, and then maybe sometimes there are a few delays at the check-in nurse. Well, those are 4 great ideas. So how do we determine which one of these could potentially be causing more of the problem or not? That's where using something as simple as a tally sheet can come in handy. And what a tally sheet does, it counts occurrences of events, and it helps to identify the most frequent reasons that a process isn't working. And it's not always what you expect. So right now we have a situation where the provider thinks that all the delays are starting at the clerk's desk. Well, we're going to see, once we provide a tally sheet. A tally sheet can also help you prioritize the areas that are going to be have the most impact for your targeted change. And then on to slide 10. So here's a tally sheet for the problem here that we are facing. Problem statement for what what the team is looking at is that they desire to determine the causes for late rooming of patients into a geriatric clinic. And so as you can see here, they went through 1 week of tallying up the reasons, and it seems like the patients do arrive late sometimes, but my goodness, look here. There were not that many folks that arrived late at the desk, or that were delayed at the desk, but what was a major impact here was that there was no room available for the provider. So there was no room available for the patients to be placed into the clinic room. Aha, so that discovered something that they weren't anticipating. So now that we have this tally sheet, what can we do with this information? And on the next slide here, entitled Pareto Chart, a Pareto chart is a way to take something, to take information gathered from a tally sheet and provide it, to place it into a bar graph of frequencies to sort of gauge which of these events may be happening more frequently. The Pareto principle is the principle of the 80-20 rule, that 80% of all effects come from 20% of causes. And this was from discovered or created by a 16th or 17th century economist in Italy who realized that 80% of the land and the wealth in Italy was controlled by 20% of the population, but then started discovering that this rule applies for many other things in life. And again, it'll help us target our area for change, for the most impact. Here's an example of a Pareto chart, and this is looking at reasons why lab tests were not being done. And as you can see on the left side, that there is a frequency count, and it just has the number of occurrences. Down along the bottom axis, we have the reasons why labs were not being done, and then along the right-hand side, you have the cumulative frequency of how that's happening. And as you can see, the two bars on the very left-hand side certainly have the majority of the causes for the labs not happening. And as you can see with the blue line there, that basically does account for 80% of the problems that they noticed with this. So now let's go to our own situation and let's see what they experienced with the late rooming of the geriatric clinic patients. So what you see here on the next slide is just a simple Excel spreadsheet that has been set up with the 4 reasons that the group that came together determined were the causes for the delay. And what they've done, they've set this up on a grid. So rooms not available, patient being late, delays with the nurse, and then delays with the clerk. And then along the top you have a baseline measurement. That's the time that they took for to measure for 1 week the frequency of these events happening. And then you can see just to the right of that, we've created this nice little bar graph that shows very clearly that the main reason that patients are being placed into rooms late is that a room was not available. Then if we go to the next slide, we can see here, just in a more clear fashion, that the discovery of the reasons why patients were being placed in the room late clearly does show us that there's one main reason that is the cause. So for our baseline measurement, we can see that the total number of times that a patient was placed in a room late was 53 times. And that's considered your baseline measurement here. So now let's go on. If we think of measurement for improvement, I'd like to take us back and think about improvement or research as a whole. And we think about that from both the discovery mentality or of basic science, how we are looking for novel and new creative things that can help improve care. And that's what happens sort of at bench research with basic science. That's new discovery, that's new information, things that have never really been discovered before. And then once the bench research has been completed, then it moves into sort of prototype discovery, where we, as scientists, try to find ways to apply that new bench knowledge into clinical care. And then we move along the continuum to phase 1 and phase 2 trials, and then even into phase 3 studies, which we all can consider our gold standard, of the randomized control trials that really tell us what the best practice or provide us the support for our evidence-based practice. And then once we are sure about our best practices, then we try to move those into health services research and then on into bedside care, which is the healthcare practice. And as you can see here, quality improvement really impacts just those last 2 portions. And just to explain that a little further, like research, quality improvement does use data to determine if change in practice is an improvement, but quality improvement impacts clinical practice, not new research. And this next slide here that speaks to the Institute of Healthcare Improvement explanation of different types of measures, I want to take just a minute to talk about the difference between measurement for research and measurement for process or quality improvement. And on the left-hand side, we start with the purpose. The purpose of research is to discover new knowledge. The purpose of quality improvement measurement is to determine if to bring new knowledge into our daily practice. And when we think about the types of tests that we do, for research it's typically one large blind test because we want to see if our hypothesis will stand up. With quality improvement, we want to do many sequential observable tests, sort of that rapid cycle PDSA that I talked about with the model for improvement. And with concern to biases, when we are doing research, we try to control for any possible bias that might affect the outcomes of our research. But within quality improvement, we just stabilize for those from test to test. You go through one rapid cycle change of your care that you're providing. And if something doesn't work, you learn from what didn't work and you make the changes with that next cycle. And with regards to data, this is really important. If you think about the gathering of data for research, you gather the kitchen sink. You get every bit of research or information that you can get because you never know what you're going to need when it comes to the analysis phase. So you get all the data you possibly can just in case. But for quality improvement, You want to really streamline things. You want to gather just enough data to learn on a very quick cycle and learn from what that information provides you, so you can then potentially gather some additional data with the next cycle. And for the duration of how quickly you want to do measurement for research, some of the research projects can take a very long time. You think about some of our long-term studies that are 5 or 10 years to look for a significant outcome. With quality improvement, these need to be very small tests that have significant change, that accelerate the rate of improvement. So these are measurements that we do on a daily, weekly, or potentially even monthly basis, but very rapid cycle. And then to the next slide, if we talk about classifying metrics, there are different types of measurements that we can use for quality improvement. And they're outcome measure, process measure, and balancing measure. And I want to go through each of these. So an outcome measure is a measure that truly affects the patient. It commonly reflects the cumulative impact of multiple care processes. And just to explain this a little bit, let's use the example of the number of foot amputations that may be performed at a facility in any given year. And I could imagine that that may be a fairly low number. So it's not something that really happens on a daily basis. So if you think, well, we really want to bring the number of foot amputations down in our clinical practice here at our facility, if we were to wait to measure just the number of amputations that we do, we may have to measure that over a 12-month time period, which is not ideal for quality improvement. But for a process measure, if we wanted to think of something that might impact the number of foot amputations, or measure a service that's provided at the healthcare delivery end, an example of that could be the completion of foot exams for diabetic patients. If the evidence-based practice tells us that if the providers do thorough foot exams and determine the patients that are at risk for foot ulcers and can intervene in those more quickly and treat those, we can impact the number of foot amputations that we may see over time. That's an example of a process measure. But with a balancing measure, when you think about increasing the number of foot exams that you do in your clinic, when you have a 15-minute visit for your primary care patient and you have to wait for them to take their shoes, their socks off, you can imagine that that's going to lengthen every appointment that you see. So what that will do is start to back up the clinics and people will be waiting longer, so you will increase your number of late appointments. Well, that's a balancing measure or an unintended consequence of the change in the practice that you're doing as you are hoping to improve the outcome of care. So outcome measures, if we look here on the next slide at this, the diagram on the right-hand side, if you start at the center of this diagram, you think of the patient. The patient's basically at the center of the clinical outcomes that we're thinking about, and we think about their biologic needs, and then their physical status, and then we have to include their mental, their social, and then overall their quality of life. Those are the things that outcome measures really impact. And some of these things are, we want to try to prevent disease, to minimize the burden of disease, and to help them maintain function. And also in doing so, we want to try to conserve resources, not only for the patient and their resources within their life, but also within the resources of the facility. So what are some challenges to outcome measures? As you can see, and we've talked about this a little bit, that they're very clinically important and they reflect the aspects of care that are provided for the patient. But sometimes they're obvious, but sometimes they're not. And they can be far removed from the actual care that's given to the patient. But can we really make those outcome measures change in a really timely manner? There are a lot of things that may impact that change. So you want to improve diabetes care, but then you have a lot of factors that you have to take into consideration. Patients' adherence to their diet and their exercise and their medications, family history, detection rates, all of those will impact the number of foot amputations. But what we have to consider when we're thinking about outcome measures is that there could be a considerable amount of time until we get to the actual number of amputations that we can measure. But a challenge to the process measures, these may be more proximal to the event that's happening, and therefore they're very sensitive to change. We have control over the number of foot exams that we do, but there's an assumed impact. We assume that if we increase the number of our foot exams that we may identify patients that are at risk and be able to intervene in their care more quickly and thus ultimately impact the number of foot amputations. But that's an assumed impact. That's where evidence-based practice and our practice guidelines come into play to help guide us into what we consider as a good process measure. And that gets us into this balancing act of balancing the sensitivity to clinical relevance. And that's one of the challenges with quality improvement, is finding that true process measure, which we're going to do for our little project here. So we've talked about balancing measure a little bit, especially with the diabetic patients. If we increase the clinical value compass that you see here on this slide, there are 4 main aspects to considering the overall balance of health. You have functional status, satisfaction, the cost of care, of course we can't ignore cost, and then biologic status. If we improve one area but neglect to think about the impact of that change on the other areas, then your value compass can sort of get off kilter. You can get unbalanced. An example I like to give is a geriatric woman with really high blood pressure, but she's very functional. You may have the goal within your practice measures that you need to have 80% of your patients' blood pressure controlled. So you give this 80-year-old lady blood pressure medicine, you bring her blood pressure down into perfect range, you meet your practice guideline goals for your facility, but now the lady has absolutely no energy and can't function. So her quality of life has gone down, but you've met your goals for providing the best care, having biologic status, having better control over her blood pressure, but you're off balance a bit. Oh, sorry, this slide is a bit garbled. I tried to change it before the lecture. But measurement for change, I can try to talk you through this. Let's see if I can click to the next one. So if we think about our case study and we consider some outcome measures for the folks that we are trying to get into the rooms, if folks are having to wait for their clinic appointments, it could have an impact on their disease management because then the provider is rushed and can't get to the patients in a timely manner. So outcome measures for this group, for the case study, could be improving disease management, improving patient-provider satisfaction by having a clinic that runs smoothly, and also some cost savings. If your clinics are running too long, you may have to be paying for some overtime, which can be very problematic for a facility that's running a tight budget. So then that makes us think of process measures that we could measure that could potentially impact that outcome. Well, the first thing that comes to mind when we looked at our tally sheet was, and our Pareto chart, was the timely placement of patients into the clinic room. So one idea that we could come up with is potentially adding an additional room to the clinic structure. In doing so, if we think about a potential balancing measure, if we add a room, who do we take that room from? We may be decreasing space for someone else, and in this case it's taking a room away from the check-in nurses, or we could be displacing another group of clinic providers. So that has an unintended consequence or an impact on someone else. But if we now go back to slide 23, or the measurement for baseline status, and just refresh our minds, we see that by adding another room might truly impact the biggest problem that we were facing. Now, we could choose to address any of these other 3 problems, but if we hadn't done this Pareto chart and the tally sheet, and we had chosen to go with our gut instinct and focus just on the delays at the clerk's desk, based on these numbers, do you think we really would have a great overall improvement in what we were doing? Probably not, because it turns out it wasn't that big of a burden. But what we can see here is that truly there's more bang for our buck if we focus on the room. Okay, so measurement for change. What measurement? This is the measurement that is directed by what you want to evaluate. And for us, we want to evaluate the number of patients placed into the room on time, or the patient in this case that are placed in the room late, and reasons why that they are placed there. So when we think about, okay, now we know we need to change something, how do we give ourselves some guidelines to keep us on track? Well, that's where a strong aim statement comes into play. And if you think back to our model for improvement, the aim statement was really the first thing that's on that list, is defining what we want to do. And so for a SMART aim statement, we want to consider a statement that is specific, that's measurable, that's achievable, something that we can actually do, something that is clinically relevant, and that is time limited. So we want to, an example would be to say, we will improve X process by Y% for this defined population by this particular date. And so for our example here, if we were to think about a SMART aim, we could say, working as an interdisciplinary team, we will reduce the number of late rooming of geriatric patients by 50%, which at our baseline was 53 per week, down to 26 per week within the next 4 weeks. So as you can see, it's specific. We've said exactly how much we're going to decrease by, from 53 to 26. It's measurable. We know from our Pareto chart and our tally sheet that we have a method that we've already defined how we're going to measure. And we think it's achievable. We've given ourselves 4 weeks, so that's time limited as well, and it's relevant. If that's how we feel we can decrease the delays in clinic and provide more efficient care for our patients. So I hope that makes sense to everybody. Now, the 3 A's of good metrics for quality improvement. I always like to think of things that are agile, accurate, and accessible. You want data that you can collect and act upon very quickly. We want this to be very rapid cycle. Baseline measurement was measured in 1 week. If you want something that's accurate, you want things that has very little weekly variability. The check-in process for the clinic is pretty much the same every single week. So there's not a lot of variability there. So you have some reliable data that you can collect on a weekly basis. And it's data that's accessible. You've already proven through your measurement for discovery that you have a way that you can collect this, and it's under your control, something that you can gather. So how do we then focus on what we want to change? And there are different concepts of how you can say, okay, great, I know I need to change this, but how do I go about this? Here's a list from the Science and Art of Improvement, just some ideas. You know, you can eliminate waste, improve the workflow, optimize your inventory, change the work environment. You can focus on time, focus on variation, error proofing. You want to take out any mistakes or problems that might be happening, and then focus on the product or the service. So if you just sort of thought about our problem for a minute, the things that came to my mind were, well, let's try to improve the workflow and optimize our inventory. Measurement for change. So let's decide what we're going to change. So lack of room availability was the main cause. So let's address that. So for 1 week, what they wanted to do was to add an additional room for clinical evaluation. Room was previously used by the additional check-in nurse, so we're going to see if there was an impact when we do that. So they're going to measure for a week to see how adding this additional room changes their overall numbers. So how did we do? And as you can see here on slide 31, that we have here on the blue line, this is our room not available. In the red, we have patient was late. Green is the delay at the nurse's station, and then the purple is the delay at the clerk's desk. So that's our baseline. And if we look to week 1, well, clearly the blue line has dropped significantly. It looks like we've gone from 33 to 23. Not bad. That's a pretty good change. But what's wrong with the green line here? Something's happened there. So we've made a significant improvement in really what we wanted to focus on, but there's an unintended consequence here. All of a sudden, now there are more delays at the nurse's station. So that's a balancing measure that you have to account for. So the group, this team, the quality improvement team, got back together after week 1 and said, we got a problem, we got to address this. So the results of the PDSA cycle number 1 was that we did improve the late rooming only by 6%, because overall it went from 53 to 50. But something happened. You know, there was a balancing measure that presented itself. The check-in process was slowed down, so the nurses were struggling to get the patient's vital signs done and get them into the next room. So with the next cycle of improvement, we incorporate that data. So what they did, they took that room back, gave it to the nurses, and then asked another group of folks that were borrowing one of the rooms if they could have that room as well. So they continued to increase their number of rooms they could see patients in, but gave the nurses back their space. So here on week 3, we now have a 34% improvement. And if we look at the overall numbers down at the bottom on slide 33, we've gone from baseline of 53 to week 2 at 35. All right, it looks like the group is on the right path. So let's see. Improvement, they were able to get the numbers down to 33. So you would, or excuse me, 34%. So PDSA cycle number 3, they want to continue that same process to see. And as you can see, again, this is the simple Excel spreadsheet where everything is just clearly defined. And this is the easy way to create these beautiful graphs that you can use to display your changes. By week 4, that they really had accomplished what they wanted to accomplish. The goal, the aim statement was to decrease from 53 to 26, and they were able to accomplish to 25. And we can see here on this modified run chart over time, down at the x-axis, the baseline week 1, 2, 3, and 4, and then the goal line here right at 26. And you can see with each week we have the decreasing numbers. And so they were able to accomplish their goal within that 4-week time frame. So let's go back and sort of recap. We've taken a complex process, or a simple model, and applied it to a complex process. And in doing so, if going through these steps with this clinical scenario, it has guided us to think very clearly about defining success. How are we going to say that we've made an improvement? And it allowed us to create some concrete forms of measurement that we could really tangibly grasp to say, okay, this is really what we're going to measure. We're going to measure it the same every week. And to use those measurements to really evaluate for improvement. Again, to think about how we were able to build upon each of our PDSA cycles. The first week when they made a change, they planned an intervention, they put it into play, they measured for a week, they studied the results, realized that they needed to make some adjustment and to act upon that and to improve, and then go into a second cycle. And as you can see, if you do this over an iterative process, you know, if you start there on slide 39, with one PDSA cycle, you make a little improvement and you adjust. Then you do another cycle and you get more improvement. So over time, the complexity of the improvements that you make really start to add up. So you do multiple small interventions to provide an overall outcome of improvement. So in summary, if we think about measurement and the impact of change, these are simple strategies for improvement that can be used in any clinical setting, regardless of the size of the complexity. We've used an example of one little clinic space that's very small with a very small problem. But these same steps, these same processes can be used from a systematic approach. Our system leaders use this same methodology to look at systematic problems from across the facility. So no matter what size of the project you're focusing on, these strategies work. Outcome measures can sometimes be a little too distal for measurement in a timely fashion. But in recognizing that, we can identify process measures that can be collected in the same method as our baseline measures to hopefully have that impact over time on our outcome measures. Process measures are very important to identify so we know where we're starting from and where our goals are and how we're going to measure and determine if we get there. And simple measurements over short periods of time offer a quick way to evaluate for a larger impact of change. So with that, I know that was a little rocky at the start, and but I think we caught up a little bit, and I've got some time for questions. If anybody would like to post some questions, I'd be willing to take questions or comments. Thank you. So I have seen a question here asking if the presentation slides are available. And yes, they actually are on a website, and they are on slideshare. Lauren, is it .net? Slideshare.net /CALLAWCL, and you can get a copy of the slides there. Right, but they're available. You can they're going to be there permanently, so you can review them as often as you would like.
You guys see these questions? I could write it up here. I want to thank everybody for joining us and hope that you have received this information. And I can unmute a few more folks here.
Dr. Callaway-Lane?
Yes.
Hi, this is Dr. Howe. I've been trying to chime in as a discussant, but I've been muted and I could not get in on live meeting. I wanted to thank you for an excellent presentation on measurement for quality improvement. And I wanted to open it up to discussion of everybody, even though it's not on live meeting, to see if there are any questions for our speaker. Again, this is Judy Howe, and I was asked to serve as a discussant and to moderate the questions. I know that this has been a little technologically challenging, and I apologize. Dr. Callaway-Lane, I was interested in the origin of the PDSA cycle. Can you tell me in what environment that was developed in QI?
Certainly. I think we take a lot of our quality improvement work from the business environment. A lot of it comes, we can think of different industries that have worked on this, with manufacturing being one, and it dates back several decades, so we are certainly new to this as a profession. But I think the Institute for Healthcare Improvement has modified this and developed this from some medical providers that were familiar with the business models that were focused on improvement. So the PDSA cycle and the model for improvement itself really was developed with healthcare in mind. So that is a great question. I need to pull up my resource here, and I can maybe potentially give you the reference. I may take a minute.
Another question while you're looking for the reference, Dr. Callaway-Lane. I was wondering what the typical time period of a PDSA cycle is. And the illustration you gave us about late rooming, it was 4 weeks. Is that typical in a clinical setting, or could it be longer, such as 6 or 8 weeks?
It can be. Depending on the scope of the project, it may take much longer to go through the development stage. Once you are at the point of measurement, you really want to try to define your measurement, things that you can measure either on a daily or weekly basis. There may be some benefit to some projects to measuring on a monthly basis, although that can be a longer time frame and a little bit more cumbersome to keep up with. But with QI, you really want to try to focus on very rapid events that happen on a daily or weekly basis that you can do. So depending on how you set your goal and what your aim is, you can determine how long it may take you to accomplish that. Right now, we coach clinical providers throughout the VA system across the country through a geriatric improvement project. And from the start to finish, the development of their team to defining their problems through implementation and measurement, we allow for a 6-month time frame. So it's not unusual from start to finish for even a simple project or one that's very narrowly focused to take about 6 months total. That's a great question. Thank you.
Okay. I have a few other questions, but I don't want to take up all the time with my questions. Are there any other questions from the participants on the call today? Please just chime in, unmute yourself if you have a question. Okay, while you're thinking, I was wondering if for reasons of reliability, when you collect data in a Pareto chart or through other measures, is it important to have just one person collecting that data, such as an assigned nurse or clerk, rather than having multiple people collect the data?
I think that's a great question that speaks to the rigor of the information that you receive. And from a research perspective, yes, it would be fairly vital to have that controlled in a very clear, defined way of gathering that data. It's less stringent for quality improvement. If you are doing this within a team, if you define a tool that is simple enough and you have conversations and come up with an agreement like if we go back to our example for the session today, if you ask the clerk to count how long how many patients it took more than 10 minutes to get them checked in, and that would be counted as a delay. The clerk can do that, and then the nurse can maybe keep a track of how long that a patient was there, or how long it took for a patient to come in to be seen. Setting the definition of how you collect that tally sheet, you will get some inter-rater reliability or differences, not reliability, differences within the people that are collecting the data. But with quality improvement, it's not as important as the rigor that's required for research. So you sort of roll with those punches. If you notice that there is a large difference, if two people end up collecting the same information and get dramatically different information, then that would be something to incorporate to your next week's cycle of collection. So that would just be some shared information or learned information that you would adjust to it and take into consideration with your next PDSA cycle.
Understand. Are there any questions from the participants? Dr. Callaway-Lane, I was wondering, I have one more question. Since this is quality improvement, institutions do not require, or generally do not require, that the project go through the full institutional review board review, correct?
Correct, and that is a wonderful question. If you are doing a project there within your clinical environment and you are applying evidence-based practice that is standard of care, and you are doing it as a means to improve the actual care that you're providing for your own patients, then that is not considered research. So you don't need to go through the rigors of the IRB process. However, if you want to take this wonderful experience and you come up with something really great and you think, well, I need to write this up and publish this, there are some facilities, and I preface this that many facilities are different. They may ask that you present your quality improvement project to the IRB so they can review it and give their blessing and say that this is exempt, that it did not impact patients in a negative fashion, and allow you to get an exempt approval and then allow you to publish that information. But it's only if you are focusing on future publications would that be something that you would want to go to your committee to ask them about. But for the simple projects that you do in your own clinic for the sake of quality improvement, do not need IRB. You are right, Dr. Howell. Thank you.
Dr. Callaway-Lane, can you hear me?
Yes.
Yes, we have one more participant question. We just have about 2 minutes left, but the participant question was that it seems that this presentation speaks to lean training principles. Is that correct?
Absolutely. In one of my larger lectures, I like to compare many of the quality improvement models. There are very many different models of improvement. They all have a little bit different language, but the message is the same. So whether it's lean or Six Sigma, or with Six Sigma you've got DMAIC as opposed to the PDSA, and even within the VA itself, if any of you are familiar with your VA systems redesign, the VA has their own sort of model for improvement. It's called VA TAMX, which is wonderful. It's VA, of course, but it's actually for vision and analysis. And then it's for team, aim, map, measure, and then spread and sustain. So VA TAMX, it's a really wonderful model. But all of these quality improvement methodologies, they all speak the same language. It's just in a little different words.
Thank you, Dr. Callaway-Lane, and thank you, Dr. House. Thank you, all of you, for being on this webinar today. And despite some technical difficulties, we hope that you have enjoyed the content and the discussion. Please, to close, contact me at lauren.jones@va.gov if you'd like to obtain any additional information. We thank you for being on this afternoon. And on behalf of the geriatric scholars, I would like to thank you, Dr. Callaway-Lane and Dr. Howe, for this great presentation. Thank you all very much for being on. And goodbye.
Thank you. Thank you. Bye.
Bye.